I would like to present my dear friend, Professor Islam Anan. Islam is the founder and CEO of Excite, lecturer of pharmacoeconomics in Faculty of Pharmacy, Ain Shams University, lecturer of health policy, pharmacoeconomics and pharmacoepidemiology in MIU and Future University, health policy and health economics consultant to the Presidential Initiative Department of the Egyptian Ministry of Health, health policy and economics consultant in the UNICEF, and lecturer of medical journalism in AUC. Right? I know everything about him.
Thank you, my dear friend. Thank you for the marvelous introduction. I really appreciate it. And good morning, ladies and gentlemen. Good morning, my dear professors, Your Excellence, Dr. Hussein, and congratulations on the marvelous opening. And I guess this is my 5th or 6th year for the OncoEgypt. I'm really pleased, as usual, to be among my professors, my colleagues. So it's very hard in just 25 minutes to talk about the concept of 20 minutes to talk about the concept of health economics, which we usually teach in 2 years. So I figured that it's going to be easier if I present some case studies regarding health economics. So that's my conflict of interest, and excuse me because of the time constraint, I will be running some slides to make it in 20 minutes. So in introduction, we usually talk about cancer regarding efficiency for spending. And if you go for the Journal of Cancer Policy, you will find a lot of papers. And unfortunately, as practitioners, we usually neglect somehow the health policy and health economics of the domain and the discipline that we are actually practicing. But we always collide with the need that we would like to prescribe the top-notch innovative medications, but the health policies of my reimbursement system, my insurance, or for example, there is a budget constraint. How can we solve that? And hence the science of efficiency emerged. And you can find that in the Journal of Cancer Policy, they are focusing mainly on financing. How can we find alternative source of funding for cancer innovative treatment? How can we make sure that every dollar spent is actually spent in the right place? And you can find that the recent model in the Journal of Cancer Policy is focusing on economic evaluation and budget impact analysis and finding alternative source of funding for health financing. And you will find that in every single guidelines issued since 2015. You will find that even in the ESMO for any cancer type, they insist that if you're going to select a medication or a treatment regimen, you need to focus on cost effectiveness. Hence, we are not only focusing on clinical trials like before, we are focusing as well on real-world evidence and efficiency studies. And as mentioned earlier, that we are expecting a lot in the pipelines. And we are spending almost this year $200 billion on oncology medications. And hence the health economics and technology assessment have been established, and we are lucky here in Egypt. And I guess it needs celebration as well. And I would like to take this opportunity to congratulate Dr. Lobna on the marvelous achievement for Women for Oncology. And also to mention that one of the achievements for Egypt in leadership of health economics, that we were the first country to actually establish health technology assessment and health economics in Egypt in 2015. So some case studies. And we do have a big problem when we are talking about the CAR T-cell therapy for large beta cell lymphoma patients. And in Canada, they face the same problem as well. And usually when we are faced with this problem, we all the time think about price. What will be the price per medication, per patient, that whether we can afford or not. So since it's a new treatment, it's a very expensive one. The immediate budget is actually questionable, always from the PT committees. And the high cost of CAR T cell therapy means that sometimes patient will be left behind, but sometimes we need to select, we can for some time select high-risk patients for CAR T cell. So the summary of the study they have done in Canada is, it is cost effective. However, we need to select only relapsed patients, but not for first line. They found that for first line, it's not cost effective. But this is for Canada, maybe in some other countries, because we do have different pricing strategies for CAR T cell that it can be cost effective in another country. So the study managed to segment patients based on health economics, whether this patient will be eligible for CAR T cell therapy or not. That's one of the most famous case studies this year. Another one for the precision diagnostics. And we know now that precision diagnostics is the top-notch innovative technique for diagnosing a lot of cancer, especially for precision medicine. And this study was done for non-small cell lung cancer in UK. And you know, of course, how much it costs, whether we are talking about immuno-oncology or we are talking even about precision medicine diagnostics prior to the treatment. And because it's of a very high cost, it's very important to understand the cost effectiveness, not to be selected for all cancer types. And the summary for the cost effectiveness published this year in UK that diagnostics, it's still expensive in terms of cost. However, for some certain patients, it's better to properly diagnose them than actually to empirically treat with any cancer therapy. And the conclusion were that the precision decision diagnostic testing can be cost-effective approach. However, they recommended that in order to be included in the reimbursement system, we need to do a budget impact model and we need a managed entry agreement with the company. It means that cost effectiveness managed with the manufacturers to decrease the cost of diagnostic, and they took a lot in the managed entry agreement in regards to the cost effectiveness model. So cost effectiveness can play a role either to segment patients in terms of treatment or to push on the pharmaceutical companies and diagnostic companies to decrease and reduce prices, so we'll be able to better put an efficiency model for the diagnostics. So if we go to the science itself, it's very simple what we are doing regarding the presidential initiative and the Ministry of Health regarding the Unified Procurement Authority, and what we are doing there is we compare the budget in regards to the outcome. And usually we compare not only the price, we compare the direct medical costs, any treatment included in the treatment itself, the direct non-medical as well, whether the cancer patient will be commuting to take their treatment. For example, if we are talking about IV infusion, they need to go to the hospital, there is an IV chair, there is a transportation fees, there's sometimes relocation or hotel accommodation, and some countries are actually paying the patients the honoraria or the fees for the relocation or the hotel accommodation, like what's happening currently in Sultanate Oman. And in Egypt as well, we are actually as well approving the cancer patients. No worries.
Sorry for interruption, but I would like to welcome His Excellency, previous Minister of Health, Professor Awad Tajuddin, for accepting our invite. And our president consultant for health issues. And thank you so much for coming with us in the Women for Oncology session, Professor Awad, and it's our honor to have you with us. Sorry for interruption, Dr. Islam, and let's continue the presentation.
So as we were continuing, so what we are doing in the presidential initiative in terms of health economics, for example, or for cost categorization, that we are not only depending on the price of medications, we as well depend on the comprehensive cost categorization of direct non-medical, as I was illustrating, and sometimes if it's a societal perspective, we depend as well on the productivity lost, which we call indirect cost. So we compare the cost. So we are not comparing anyhow currently the price itself to the outcome. And because we are talking cancer and it's a high morbidity, high mortality disease, we are all the time depending on the quality adjusted life years. So we compare the cost with the quality adjusted life year, and just a very simple approach that why we are actually depending on the qualis is we depend on mortality endpoint, which is usually the life year lost, and in oncology we depend on the overall survival. But morbidity is as well a very famous endpoint, an important endpoint as well. So it is measured by quality of life, but in oncology it's a progression-free survival. But how can I actually combine the life years and the quality of life in one single unit? Hence, we are calculating it based on QALYs, quality adjusted life years. So if you look at the guidelines I was referring to at the ESMO or any guidelines for cancer in the previous 10 years, you will find that we are not anymore depending on the clinical trials only, which what we call an efficacy studies. Recently, we depended as well on effectiveness real-world evidence studies, which is the registries we are doing. Hence, it's very important to have registries for cancer, and hence we do have the strong registries for the Presidential Initiative for Cancer. But from 1993, which is very recent, any guidelines, you will find that they added another E, which is efficiency. So currently, if we would like to make any adaptation for the guidelines or for the clinical protocols, I was even lucky to attend the Egyptian Council for Health, invited by Professor Hussein Khalid, and as they were actually adapting the clinical treatment in Egypt, they will depend as well on clinical trials. It's a real-world evidence as well for tracking, and you need as well to put the aspect of health economics, which is efficiency. A very famous rule, if you would like to adapt the clinical guidelines in your hospital, is you can take clinical trials as is. Efficacy studies can be extrapolated. So regardless the clinical trial is done in Italy, it's done in Spain, it's done in the US, you can just simply take the endpoints to Egypt. But if it's a real-world evidence, effectiveness studies, it's better not to take a study done in another country and replicate it or take it as is. But if it's a health economics, efficient studies, you cannot. We never take any cost effectiveness or health economic study from another country and just adopt it as is with the same results to Egypt. Currently, we are doing mainly cost minimization and cost utility analysis for the Unified Purchase Authority, Shura al-Muwahhad, or for the Presidential Initiative, we do as well a cost benefit analysis. So I will present just one case study for the value studies is when we find that the medications are with similar outcome, or we cannot actually find a superiority in clinical trials between two medications, we do a cost minimization analysis. And in cost minimization, we compare cost versus cost. So for example, we are not talking about price. If we do have two medications, one of them is $8 and another one is 1.5 per pill, we never compare price of the pill currently as per the Egyptian law as well. We deleted as well the law of قانون 89 للتسعير, the law of 89 decree. And currently we calculate all the cost, the pharmacist salary, which is the time cost, the nursing salary, and the supplies. You will find that the medication priced on $8 is actually less in cost eventually. There's a very nice case study as well done for the subcutaneous versus intravenous trastuzumab in Chile, and they compared all the direct non-medical cost of intravenous trastuzumab versus subcutaneous trastuzumab if it's home administered, and they compared the price, and the price of the subcutaneous was actually higher than the intravenous. However, and you can see that we are taking all the cost of the salines, IV tubing, the needle, disposable syringes, and the administration as well, and we compared it to the cost of the subcutaneous. Although the price of the subcutaneous was slightly higher, eventually it's less if you're gonna administer it home-based. But this study was beautiful. Why? It's not because they managed to adopt the subcutaneous, they managed as well to decrease the price of the biosimilar. You know, the biosimilar is still intravenous. So they managed from the health economics perspective study to decrease 25% from the biosimilar. The cost effectiveness studies that we are following depends on the QALY. For the QALY calculations, what we are doing is, and this is just an example for the patient chart, we compare the utility of the patient to his life year. Utility is a quality of life. So imagine that this is a single patient chart, and he got cancer at the age of 40 and he died at the age of 41. If so, there is in literature two medications, medication A and medication B. We found in literature medication B will prolong overall survival till 60 years. So we are talking about 20 years extra survival, and there is a treatment C which is 10 years more, but it's a better utility or a better quality of life. So the healthcare question will remain, should I adopt B or C? What we are doing is, because we cannot take only survival, it will be B, and if we take only quality of life, it will be C, that we need to generate QALYs. Of course, it's not that simple, but just as a concept, we calculate area under the curve, and you will find that C generated 5 QALYs versus B, which generated 4 QALYs. Of course, there's another step, which is the cost. We compare the QALYs generated from any cancer treatment to the cost. I will jump to the last case study, which is what we have done in the breast cancer initiative. So I will jump this one. Yes. We are expecting as well the results of the economic evaluation of the other cancer initiatives, but for breast cancer, and I will finish with this case study, we would like to evaluate, we've done like 30 million females screened in the presidential initiative, but what is the return on investment? If we screen 30 million females, do we have any return on investment? And second, what will be the cost benefit? Should we continue actually screening for breast cancer? And third, what will be the continuation time for breast cancer screening? So we do have a big burden coming from the high incidence and prevalence of cancer. And this is the first step if you'd like to run any presidential initiative, to understand the epidemiology and to know that you do have a significant epidemiology in terms of incidence, prevalence, remission rates, and mortality. And of course, these numbers are currently updated. We are talking about almost double these figures, which is issued last month. So we do have high incidence, high prevalence, and we do have high burden. From a cost calculations for the burden of disease, we are talking about a $3 billion burden every year because of cancer. This is Egypt only, not global. Egypt only, there's a burden of $3 billion every year. And to understand whether we can screen or not, we need to make sure that we do have screening tools, which is cost effective. We do have subjects easily attainable to find or to detect, and what will be the cost. So whether we are screening or early detecting, it's an early detection. And all the time, early detection is a better approach to start before the screening itself. And all the time ask about the screening costs, setup costs, staff training, call-up procedures, counseling. What is the cost of finding one treatable case? We need the answer to that. What is the cost in order for one person to benefit from the presidential initiative? And what are the potential savings which might result from the screening? What is the cost effectiveness of the screening program, the cost benefit, and the sensitivity analysis? How? What we are doing is we run a decision tree based on two scenarios. First one is we run the screening, what will be the results? And second, hypothetical scenario, what if we didn't do the screening itself? And we depended in the decision tree on the primary care investigation, so there is no mammogram for all. And if so, at risk, it will be the oncologist physical examination, pathology and biopsy, and finally, the stagings. And the other one is we are talking about there is no cancer, what will be the cost? Of course, in here, it's better because we are saving a lot of money of the screening cost itself, but we are discovering patients in the late stages. We run for the cost benefit analysis a Markov model, which is patients are healthy going to breast cancer stage 1, 2, 3, and 4, and finally the stage of death. And before campaign, the levels of breast cancer stage 1 or 2 were actually not that high compared to stage 3 and 4. So before the campaign, we had a significant higher percentage for stage 3 and 4. But after and during the campaign and after the result, we'll find a 50% decrease in advanced stages, which is mainly where it's coming the cost benefit from. So for the result itself, and this result were actually cut off on the 23 million Egyptian females. We can see that the return on investment for breast cancer, it was 38%. It means that for every Egyptian pound spent, we returned around 1.5 Egyptian pounds, and we saved almost 1.2 billion. The 1.2 billion, it's coming from the early detection, finding a cure, and this year, it will be 1.2 and it will be 38 return on investment. But after 2 years, it will be better because you spent most of the screening budget in the first 2 years. So it will be better after the third and the fourth year as well. The difference in qualities were actually significant for the campaign. We generated 63.7 thousand qualities versus 50K qualities. And for the life years lost, we are talking about less life years lost for the campaign arm versus no campaign arm. So we are talking about incremental 14K qualities and incremental around 30,000 life years saved at the arm of the campaign itself. Okay, that's it. And one final message before my recap is, if we would like to continue in the cancer screening and the adoption of clinical protocols for cancer, these two should be walking hand in hand. And we should actually do the forecasting of any cancer screening with the treatments, because it will even help that we can decrease the price of innovation. We can all the time make large volume agreements with the pharmaceutical companies, which is currently happening, because we are not just entering a new molecule for the case of 2 or 3,000. We are screening 30, 40, and 50 millions in some presidential initiatives. I believe this will be the future for two things. First is better cure for patients, and two, because I'm a health economist, financial sustainability, which is very important given the current circumstances. Thank you.